Hello and welcome to today's webinar. My name is Christian Yadav. I'm an emergency physician at the Ottawa Hospital with the Department of Emergency Medicine in Ottawa, and I'm an associate scientist with the Ottawa Hospital Research Institute. My main area of research interest involves improving the care of ED patients with skin and soft tissue infections. On behalf of the Canadian Association of Emergency Physicians, I'm delighted to be here for what I know will be a very useful and interesting session as we cover optimized management of skin and soft tissue infections in the emergency department. Our webinar topic was independently conceived by the Scientific Planning Committee, which involves Drs. Eddie Lang, Stacey Kitts, Kirat Grewal, and Peter Iraklius. And my disclosures here are as follows. I did receive an honorarium from CAPE, but have no other disclosures to declare. This program did receive support in the form of an unrestricted educational grant from Paladin Labs and did not receive any in-kind support. All efforts were made to mitigate any potential biases as shown on this slide. So we came up with this topic because while skin and soft tissue infections seem like very simple clinical presentations on the surface, they're often anything but. There's a lot of things that emergency physicians have to consider with respect to making the accurate diagnosis, watching out for diagnostic mimics, finding the optimal management, so what dose, route, and agent, and whether patients need to be admitted to hospital or can they be sent home. So with that in mind, we have four main learning objectives for you for this webinar. First, we want to identify the current burden of disease and microbiology with respect to skin and soft tissue infections, specifically the ED setting. Then to look at optimizing management of SSTIs for ED patients. And we want to go over some clinical pearls in terms of detecting more serious deep space infections like necrotizing fasciitis. And finally, to use a case-based approach for treating SSTIs in the ED setting using new antimicrobials that are now becoming made available in Canada. To increase the interactivity of the session, we would strongly encourage you to use the chat feature to submit any questions, and we will do our utmost best to answer as many of these as possible at the end of the session. We will also be doing some audience polling using Mentimeters. So there's a QR code on this slide. We would encourage you to scan that, or you can put in the code through the website in order to answer a couple of polling questions that we'll have for you. So without further ado, I'd like to introduce my esteemed colleagues who will be sharing their expertise today. First, I'd like to introduce Dr. David Talon, who joins us from California. He is a board-certified emergency medicine and infectious disease specialist who is considered an authority in the area of acute infectious diseases. His research focuses on ED-based surveillance and epidemiologic research of emerging infections and clinical investigations of acute infections. He is the principal investigator of a CDC-supported ED-based research network for research on emerging infections in the United States. And this is entitled Emergency ID Net, which was established in 1995. His specific areas of research have included skin and soft tissue infections, animal bite wounds, pyelonephritis, meningitis, sepsis, and non-operative treatment of appendicitis. Dr. Talon's disclosures are on this slide, and we're thrilled to have him with us tonight.
Thanks, Christian, and nice to be here and see my friends from Canada.
Thanks, Dr. Talon. Our second esteemed speaker here is Dr. George Zanel, who is a microbiologist and pharmacologist who is currently full professor, Department of Medical Microbiology and Infectious Diseases at the Max Rady College of Medicine, University of Manitoba. In addition, he's the director of the Canadian Antimicrobial Resistance Alliance, also based out of the Max Rady College of Medicine at the University of Manitoba. Welcome, Dr. Zanel.
Dr. Yadav, I'm really happy to be here. Good evening, everyone. I'm delighted to be with all of you.
Perfect. So it's really great to have you as well, Dr. Zanel. So I'll be speaking a little bit as well in this presentation, just to give a little bit of context from the Canadian ED setting. So to start off with, let's go over the background in terms of why this clinical presentation is so important. From the United States, we know that 4 in 10 Americans visit a healthcare provider every single year for the reason for being seen for treated for skin and soft tissue infection. So the burden is quite high. In addition, we know from the US that nearly 900,000 Americans are admitted to hospital every single year for skin and soft tissue infections, which translates to a cost of nearly $5 billion US. If we extrapolate this data to the Canadian context, we can estimate that nearly 90,000 Canadians are admitted to hospital for skin and soft tissue infections. We know that in the US, over 4 million Americans visit an emergency department every year for skin and soft tissue infections. So this would translate to approximately 400,000 ED visits for this clinical presentation. And this accounts for up to 3% of all ED visits. So the burden is quite high. Given how common this is, a natural next question is, well, what do the guidelines tell us? Unfortunately, the main guidelines that we would use, which are the IDSA guidelines, have not been updated since 2014. And they've somewhat fell victim to the fact that many important trials that have answered some very important clinical questions, such as when would you give antibiotics for patients with abscesses, were published just after the guidelines were published. So as things stand right now, the current guidelines have some limited evidence to guide ED-specific management for skin and soft tissue infections. We'd like to frame this webinar around a familiar case that I'm sure we've all seen in the emergency department setting. I'd like you to imagine a 42-year-old male who presents with 3 days of a painful right lower leg. He has a history of diabetes, and you note that he has an elevated BMI. Vital signs are stable, and on physical exam, the leg is clearly indurated, hot, and mildly to moderately tender on palpation. So there are very important things for the emergency physician to consider. First of all, making an accurate diagnosis. And this is where the role of point-of-care ultrasound is really, really important. And so POCUS can be used to make sure that there is not an underlying purulent collection. We know from the literature that the sensitivity of POCUS for this is 95%. After you make the correct diagnosis and rule out an underlying abscess, there are other important questions to consider. Does this patient need oral or IV antibiotics? Whether they need oral or IV antibiotics, what is the optimal agent? What is the optimal duration of therapy? And does this patient need admission to hospital, or can they be discharged home? And importantly, how can we be sure we're not missing any type of deep space necrotizing infections? So this brings us to our first clinical question, which is to consider when we see this patient, what are the main pathogens to consider? And so we have our first polling question for this webinar. So we'd like the attendees to consider this question. What would be the most common bacterial pathogen in Canada for all infections, E. coli, Enterococcus, Staph aureus, Streptococcus, or Pseudomonas? And for you to also consider specifically for skin and soft tissue infections and wounds, what would be the most common bacterial pathogen to consider? So we'll give you about 20 seconds to answer that, and then we'll turn it over to Dr. Zanel to give us some insight.
Thank you, Dr. Yada. I'm just waiting for our polling question to come up. What is the most common bacterial pathogen in Canada for all infections? So this is you. You're in the emerge. A patient comes in. What are the most common types of pathogens you're worried about? I would like you to think of two things. E. coli is the #1 most important. Now I'm talking all infections. On the next slide, I'll do skin soft tissue because I see you've got the skin soft tissue down. For all infections, I want you to think that E. coli is the most common pathogen in Canada, including in the emerge. In the emerge, E. coli is the #1 cause of all urinary infections, cystitis, pyelonephritis, acute bacterial prostatitis, chronic bacterial prostatitis, #1 cause of bacteremia, #1 cause of sepsis coming into the emerge, and it's a #1 cause of intra-abdominal infection. So E. coli is a biggie in terms of all infections, patients coming into the emerge. #2, in terms of all infections coming into the emerge, Staph aureus. Staph aureus is the #1 cause of skin soft tissue infections. We'll talk about that more in the next slide. It is the #2 cause of all cases of bacteremia and sepsis, including in the emerge, and is an important pathogen, as you know, for all of you, especially in patients who do intravenous drugs. You're worried about the pathogen not just gets into the skin soft tissue, gets into the blood, maybe endocarditis, a septic joint, etc. So when it's all infections, all pathogens in the emerge, think E. coli is a biggie, think Staph aureus is a biggie. And Krish, I'll go on to the next slide and I'll focus more on our topic, which is skin soft tissue. So getting back to our topic, you are bang on. #1 cause is Staphylococcus. #2 are Streptococci. I like the Emerge doc to think of wounds as into two categories: purulent, pus forming, those are all your abscesses. That's a staphylococcal disease. That's Staph aureus, could be MRSA, less likely streptococci. Non-purulent, cellulitis, we're below the skin layer here. Typically, this is a streptococcal disease, such as group A or group B strep. It could also be Staph aureus, but much less likely. So you're bang on. Skin soft tissue is staph and strep. Purulent, more staphylococci than strep. Non-purulent, more streptococci than staph. And now, Christian, I'll turn things over to my colleague, Dr. Talon, to talk about his thoughts.
Yeah, thanks, George. I'm following the pool. You're getting excited there. I thought that question was kind of tricky because Krishan introduces us about skin infections, and then we asked about all infections. So give yourself a pass if you got that one wrong. But George, I agree with you. Staph and strep are the main things that we worry about. You showed the data on the frequency of those pathogens for all wound infections. And MRSA, I think, accounted for about 10 or 11%. And but that's something to kind of think about, because 20 years ago, we never saw MRSA from a wound infection, especially from a patient from the community. And then something changed around the time of the millennial change. And so for you epidemiologists out here, you'll like this. This shows you the frequency of skin and soft tissue infection diagnoses coming through US emergency departments over time. And it starts at 1993 and goes through 2005. And you can see that at the time of the millennium change, the number of cases shot up dramatically in US emergency departments. And I know the same thing was observed in Canada, because it says it right on the slide. So my colleagues and me, you'd work shifts and used to infrequently see someone who you'd have to drain their skin abscess. And then all of a sudden it seemed like during a shift, you'd have 3 or 4 of these patients. And something really changed. And we wondered what changed as we started to see MRSA sometimes grow from some of these cultures. And so we put together our network, the one that Krishan referred to, called Emergency ID Net. And it was formed in 1995 and funded by CDC with the idea that emergency departments are good places to look for things, to do surveillance for emerging infections. And here's one that we suspected. And give me the next slide, please. And it led to this report in the New England Journal of Medicine in 2006, methicillin-resistant Staph aureus infections among patients in the emergency department. And like George referred to, what we focused on were people who had culturable, purulent wound infections or abscesses. And here's the result of that study. You give me the next slide. And we had about a dozen sites. And in 2004, among these cultured purulent skin infections, MRSA, which had not been seen as a pathogen routinely before this time, now accounted for the majority of infections, almost 60%. And the editorial that accompanied this described this as a landmark study and noted the amazing extent to which community-associated MRSA, and this was particularly a clone called USA 300, had spread across the US population and most of the world, including Canada, Europe, Central, South America, and Asia. There's still some places where they don't see MRSA, like Scandinavia, and I'm not sure anyone understands it. It might be too cold, but then what about Canada? Or maybe it's just too boring, I don't know. But most of the world now has had to contend with anticipating MRSA as a pathogen. And if you look on this slide in your lower right-hand corner, you'll see reference to concordant antibiotics. In 2004, when we did this study, less than half of the prescriptions had activity against MRSA. But by 2008, the antibiotics prescribed almost always had activity against MRSA. So that changed practice. I can honestly say I did research that led to changed practice, and I think better patient outcomes, which I'll show you later, in the United States. And I think it led to changed practice in Canada. So here's where I'm going to turn it back over to Krishan. Take it away.
what we wanted to do in Canada was to understand how emergency physicians treat non-purulent skin and soft tissue infections in the ED. And so we conducted a national survey of Canadian emergency physicians to understand how SSTIs are managed and to identify perceived predictors of treatment failure. So this was a national survey of Canadian attending emergency physicians. We had nearly 400 physicians respond. We did also survey infectious disease specialists in Canada as well. And we asked important clinical questions such as, what is the first choice of oral antibiotic agent, the first choice of IV agent? How do you decide upon the route? Should the patient have oral or IV antibiotics? How long should patients get antibiotics for? And when should these patients be reassessed for potential treatment failure? So this slide summarizes the main results that we had. So overwhelmingly, the number one choice of oral and IV antibiotic was cephalexin and cefazolin respectively. And most clinicians felt that the appropriate duration of oral antibiotics to prescribe was 7 days. This is despite guidelines suggesting 5 days of therapy. And most clinicians felt that a patient should be reassessed at either 48 or 72 hours for potential treatment failure. Interestingly, up to 14% of respondents actually felt that you should assess a patient at either 24 or 36 hours for treatment failure, which you can argue might be quite premature. This table here summarizes 3 Canadian cohort studies looking at treatment failure for cellulitis. And that you can see here that overall, approximately 20% of Canadians fail treatment. So that's a pretty unacceptably high treatment failure rate where 1 in 5 patients is going to fail and require subsequent IV therapy. So this brings us to our next polling question. What would be your first choice oral antibiotic to treat cellulitis in the emergency department? Would it be cephalexin, clindamycin, cloxacillin, doxycycline, or a sulfa-medication? And so we'll give you about 30 seconds to answer that before we move on. And Dr. Zanel, we're going to have you actually jump in for this next part here. It looks like most respondents are saying that cephalexin would be their first choice oral antibiotic. So I'm hoping that you'll be able to comment on cephalexin as a choice of oral antibiotic in general.
Thank you, Dr. Yadav. Can I go back to that poll, or is it too late? Because that's a great slide to work with. So, I'm clearly preaching to my people over here. Thank you for these wonderful responses. The majority of you say cephalexin, clearly consistent with Dr. Yadav's trial. I like cephalexin for cellulitis. This is non-purulent. We think it's primarily streptococcus, such as strep pyogenes. It could be staphylococcus. I'll note that all of the drugs on this list could clinically work. All of the drugs on this list have streptococcal activity, and they also all cover staphylococcus. So this is a good list. I like cephalexin, specifically for cellulitis. Why? It works, it's safe. There's a tremendous amount of experience with emergency room doctors with using cephalexin. They know how to prescribe it. We don't have a lot of drug interactions. It's safe in all trimesters of pregnancy, even in breastfeeding. So I really like cephalexin. Cloxacillin would work. Clox covers staph strep. I note that my ER docs, when I used to travel across Canada, the US, and the world, would tell me they thought cephalexin was better tolerated by their patients than cloxacillin, but Clox would work as well. Clinda would work as well. I don't really like you using it too much in the emerge. We still do worry a lot about not just diarrhea, but as you know, Clostridium difficile infection, because we see community-acquired and hospital-acquired infections. Doxy is a good drug. A lot of our foreign grads like to use it. It would work in cellulitis. And troublesome sulfa is more of a staphylococcus abscess purulent infection drug. but there's some anecdotal evidence it would work here. So I love cephalexin. Thank you for saying that. I think cloxacillin is a great answer as well. Dr. Yadav, thank you for that. Let's move on.
Perfect. Thanks. Thanks a lot for that insight. If I can ask Dr. Talon, a thing that comes up often with clinicians is, okay, we're going to prescribe cephalexin, but should we be double covering? Should we be adding trimethoprim sulfamethoxazole to cover for MRSA? So that comes up every year when I'm working with trainees, and I'm wondering if you can give us some insights, given that you published a trial on this very topic.
Well, thanks for setting me up there nicely. Yeah, I think, you know, what happened with seeing so much MRSA, clinicians wondered if, you know, that may have also affected the etiology and the type of treatment that should be given for cellulitis, right? We presume strep is involved in cellulitis, but you can't culture anything. People have tried to do biopsies. I've done studies looking at PCR of soft tissue and special types of molecular techniques to more firmly identify the etiology instead of indirectly through like strep serologies and things like that. And we don't really know. We do know that most of the time, at least prior to the emergence of MRSA, drugs with narrow spectrum like penicillin or cephalexin seem to work just fine. But then, you know, you saw the tremendous emergence of MRSA and community infections, and many of the doctors were giving cephalexin and trimethoprim sulfamethoxazole with, you know, anticipating MRSA. So we did a clinical trial. This is a large NIH-sponsored clinical trial in the US where patients with pure cellulitis, it wasn't a wound, it was an area of redness and erythema limited to one extremity where there was nothing to culture. So it was purely a clinical trial, and patients were randomized to either get cephalexin and placebo or cephalexin and trimethoprim sulfa. And you couldn't tell the treatments apart. And then they were followed. They all had ultrasound. So POCUS is important because some, you know, very large areas of cellulitis, there'll be a deep abscess. And that absolutely changes the type of infection you have because we know abscesses are usually due to staph. So that was excluded. And then patients were followed. And I apologize that it's hard to see the numbers here, but take my word for it, we could not demonstrate a difference in clinical outcome between the Keflex alone and Keflex plus trimethoprim sulfa. So our recommendation is just like George said, that cephalexin, and our audience said, that cephalexin, but cephalexin alone should be sufficient. Among the other ones, if you happen to like trimethoprim sulfa, that would work too. Clindamycin would work. I personally would be cautious about doxycycline. Doxycycline is so notoriously inactive against strep that on the package insert, you know, package insert that comes with the drug, there's a warning against treatment of presumed staphylococcal infections. That doesn't mean it might not work a lot of the time, but you have so many other good choices. I think I would stay away from that. And there are occasional serious failures. And so I guess with that, do we go back to you, Krishan? Did I answer your question?
Yeah, that was perfect. Thank you very much. So this leads into the next clinical question that we face as emergency physicians, which is, how do we decide on oral versus IV antibiotics? This is the age-old question that we're faced with when we see these patients. We know that oral antibiotics have a number of advantages. They're more convenient for our patients, they're cheaper, and they have lower complications, whereas IV therapy is less convenient for our patients. It's costlier, and you have to contend with IV-related complications. The one benefit, of course, being that you get 100% bioavailability, although many oral antibiotics, such as oral cephalexin, will have a bioavailability of over 90%. So I'm going to turn back to you, Dr. Talon, to just go over, give us some clinical pearls here about which patients actually need, in your opinion, admission to hospital for intravenous antibiotics. And then if you could touch on some clinical pearls that you can share with us to make the diagnosis for deep space necrotizing infections, which I think we all agree is a can't miss diagnosis.
I will if you stop calling me Dr. Talon and call me Dave.
You got it.
Yeah, I mean, so yeah, one of the things that goes into our decision about using IV or antibiotics is how sick the patient is. And certainly the sicker patients get admitted to the hospital. And it's hard to find a patient in the hospital that's not treated with intravenous antibiotics. So we actually did some research on this. I'm sort of a research guy, I guess you could tell. And you know, we looked at patients coming through this network of emergency departments. And in this study, we looked at the factors that went in the decision to hospitalize a patient. And just like I was saying, use of IV antibiotics and presumed need for IV antibiotics was at the top of the list. And it was one of the reasons that the doctors gave for deciding to admit the patient to the hospital in 80% of the cases. By far the most common reason listed, and the only reason in a little over 40% of patients, which also makes us wonder, like, might there be another way to give intravenous or parenteral treatment, which we'll get to in a second. But here were some of the other reasons that it's worth looking at, and these would be obvious to you. The patient needs surgical intervention, like in the operating room. You can't do that at home. Maybe they need complex wound care, or they have a significant comorbidity that's out of control, like they have cellulitis and diabetic ketoacidosis. And then if you look at the bottom of the list, there's things like homelessness, you know, maybe persistent vomiting and can't take oral medications. And then some more serious infections like sepsis and endocarditis, septic arthritis, osteomyelitis. And the one we absolutely never want to miss, the most serious, necrotizing fasciitis. And being Canadian, didn't you have like some premier or president in Quebec? Wasn't there some famous politician who lost their leg due to necrotizing fasciitis?
What do you think, George?
You know, this is the problem. Chris is too young. I'm an old guy. Yeah, the guy's name was Dr. Lucien Bouchard. I was driving to work that day and heard on the news that Dr. Bouchard was attending some sort of political meeting. He had what looked like a varicose vein. I think it was on his right calf, and clearly Streptococcus pyogenes got inside that wound, and he had a necrotizing fasciitis that was rapidly ascending and eventually lost his leg. Absolutely.
See, so you Canadians, you're not immune. So let's talk about it. And I don't want to hear any cracks about Quebec and Quebec politicians. You just contain yourself, or we'll start making fun of people from Newfoundland. All right, so does that translate anymore? I don't know. Probably can't say that. So what are the distinguishing features? Well, patients, of course, have pain, although it's really hard to tell. I mean, we see plenty of people who are opiate addicted and wanting pain medication. So that maybe may not be enough. It's very subjective. Progression. So one thing I think you should try to routinely do with any serious skin infection is take a marker and draw a line around it, maybe write the time down and come back and see if it's twice the size. This ain't the huge. Some infections are gas producing, not strep, but you know, anaerobes like Clostridium. You may feel crepitance, that's a problem. And with necrotizing fasciitis, it can, as it cuts across the fascial plane, it can actually destroy cutaneous nerve supply. So you'll get this weird thing of something that's very painful, but when you touch it, it's locally numb. And then patients are just not, I mean, most patients with skin infections aren't that sick, but these guys look sick. I mean, you know, if they have vital sign abnormalities, that's a clue. And their laboratory tests are a little crazy. And that's where this index you've heard of called the LRI-NEC score, the Laboratory Risk Index for Necrotizing Fasciitis, came about. And you might hear maybe your surgical consultant asking you, hey, what's the score? And I think Krishan asked, like, well, what do I think about this? It was developed from research in China. Nothing wrong with that. But what they did to develop it is they took confirmed necrotizing fasciitis cases and confirmed cellulitis cases. So not surprisingly, its performance characteristics, the score, were near perfect, very high sensitivity and specificity. But guess what? When you applied it and you took out the obvious necrotizing fasciitis, and the obvious must be a cellulitis, and the ones in the middle that were, if anything, early necrotizing fasciitis, it didn't perform nearly as well. But keep this in mind, where you start to see crazy laboratory abnormalities and you have some of these features, think about necrotizing fasciitis. You may also see high CK or blood in the urine that's myoglobin from the dip. You see high uric acid, think twice that, you know, it's not gout. This could be the cell breakdown releasing the uric acid if there's these other features. And imaging, whereas, you know, this is an emergency, you're not going to park somebody for hours waiting for an MRI. If you're able to get plain film, CT, or even a quick MRI, you know, it may give you some clues, especially, let's say, if you see gas or infiltration along the fascial plane or into the muscle. Sometimes that's helpful. And that's my report on necrotizing fasciitis. Krishan, back to you, right?
Great, thanks, David, for that. That's really helpful, a number of clinical pearls there. And so this transitions nicely to the final part of the didactic portion of this webinar, which is what are new IV antibiotics in Canada for the treatment of skin and soft tissue infections? There have been a number of exciting trials that have come out in the last 5 to 7 years, and there are some new agents available to us. And so I'm going to turn it over to George to first start off with lending his expertise about some of the advantages and disadvantages and the current landscape in Canada. And then David will follow up after that.
Krishan, thank you for that. Can you, thank you for getting me to this slide. So, colleagues, I'm bringing good news and bad news on the next 3 slides. This is some of the bad news, and I'll talk about the good news shortly. Our research group, the Canadian Antimicrobial Resistance Alliance, we study every antibiotic that you use in eMERGE today, but we also study every antibiotic that you're going to use in the eMERGE over the next 1 to 5 years. And here I'm bringing bad news. This is a list, and I'm showing you 15 antibiotics. And you'll see a column that says US 15. All 15 of these new antibiotics have been approved by the FDA and launched, meaning they're available to use by emergency doctors and clinicians across the United States. That's good news there. The next column is EMA. This is the European Medicines Agency. 13 different antibiotics have been approved, and they've been launched in different numbers in different European countries, but the vast majority have launched the majority of these drugs. So I'll say 13 have been launched in Europe. And then you look at Canada, and we're only at number 3. And you can ask me why these new agents are not coming to Canada to be available for you to use in your particular practice. That you can ask me that. So the bad news is very few of these are coming to Canada. The good news is the ones in yellow. The ones in yellow, ceftolozane tazobactam, this is the premier anti-pseudomonal drug in the world. It's in Canada. We've done a lot of research on it. This is the best drug to treat an infection caused by Pseudomonas, whether it's skin soft tissue, whether it's lung, whether it's bacteremia, whether it's a ventilator-associated pneumonia. It's here in Canada. Number 8, fidaxomicin. It's a drug we've had in Canada for a while. This is for Clostridium difficile infection. Initially, you didn't use it at all. You were using oral Vanco for C. diff infection. Growingly, the new guidelines are that, you know what, fidaxomicin is in fact better than Vanco. And if you can afford it, it's a good agent to use because it's actually better than Vanco. But I want to focus on number 5, Dalbavancin. This is a new agent that just came to Canada. And I've been around for 35 years, living, breathing antibiotics and treatment of infectious diseases. We have never had an antibiotic like Dalbavancin for any infection, including skin soft tissue infection. So what I've done is I'm going to summarize my thoughts on this drug in 2 slides. Dalbavancin for acute bacterial skin soft tissue infections, or ABSSSI, and these can or don't have to be caused by strep or staph or MRSA. Let me summarize this. This is from a big review article. We've been studying this drug for 10 years. I like the fact that it is rapidly bactericidal. It kills all gram positives. Staph aureus, MRSA, streptococci. So cellulitis, abscesses, it kills all the pathogens. There's very little resistance that has been shown on therapy. Here's the game changer, and that's why I bolded it. It's one dose. You give one intravenous dose, 1,500 milligrams, and you're done therapy. And why I'm telling you this, we've done a bunch of focus groups with clinicians across Canada, and this seems to be a wonderful drug for the emerge in patients who come to see you who are IV drug abusers, homeless. They're going to leave against medical advice. They just want to get out of town. You don't want to put it in a PICC line and send them home. In these particular patients, this could be a wonderful drug. One dose IV and they're cured. So in someone who needs IV, you don't want to put in a PICC line. They're going to leave. They're never going to come back. And if they do, they're going to come back as they failed oral with endocarditis. This has seemed to be a good role for the drug in the emerge, IV drug abusers who have skin soft tissue infections. It's safer than Vanco. You don't have much less nephrotoxicity. Safer than daptomycin. You don't worry about all these muscle problems. I like the fact that you can give a 30-minute infusion in the emerge. You don't have to do drug levels like you do with vancomycin. Doesn't select out C. diff and no relevant drug interactions. So I like this drug, its potential role in the emerge, and I'm going to turn it over to David to give his thoughts shortly. But I like this drug in the emerge. IV drug abusers, they need IV. You don't want to put in a PICC line, something to consider. The downside, this is a brand new drug. Very few people know anything about it. It's not in the guidelines. It's not on the hospital formularies. So it's a brand new drug that just came out. Your job is to learn about it. When and if are you going to use it? From the microbiology side, this is us. No one does lab testing except us for research purposes. So what do? You test vancomycin. If the bug is susceptible to Vanco, it will be susceptible to Dalba. Cost, any new drug is expensive, but there's a pharmacoeconomic case to be made here because you're going to keep people out of hospital. David's going to talk about that. There's a huge off-label need here. This drug has been shown to work off-label for things like septic joints, device-related infections, endocarditis, bone infections. So it has a lot of potential for infections caused by Staph aureus and MRSA, potentially methicillin-resistant Staph epi, and even streptococci. So it's a new drug. We need a little bit of patience, but I think this is a very cool drug. So let me turn things over because we have no clinical experience in Canada, but Dr. Talon has had a lot of experience in the US because it's been out, I believe, for 7 or 8 years, David, in the US.
Yeah, thanks, George. So, I mean, I think what George is alluding to and what we've led up to is that we put people in the hospital quite a bit. One of the main reasons we do that is for their serious infections and to treat them with intravenous antibiotics. If you give intravenous antibiotics in the hospital, then you know that the patient will adhere to the drug regimen. Whereas if you send somebody home with oral antibiotics, they may not adhere, or the oral antibiotics may not achieve levels in the tissue that are sufficient in order to get the person cured of their skin infection. So Dalbavancin is one way, but to be complete, there's another long-acting single-dose IV drug called Receding, and I don't know if you yet have that in Canada. That's another option. And there's some drugs that have a 24-hour half-life, kind of like we use ceftriaxone quite a bit for pneumonias and pyelonephritis and things like that, to start out treatment so that we ensure that there's parenteral levels of antibiotic on board for a long time. And so we're comfortable with that with ceftriaxone. Giving a single dose of vancomycin makes no sense pharmacologically. It doesn't require several doses to even achieve therapeutic levels. It's obviously not a Q24-hour drug. It actually takes really a few days to reach levels that would be effective. So even though sometimes you'll see that done, it doesn't really make sense. But there are daily dosed intravenous gram-positive active antibiotics, daptomycin, which wasn't very expensive, but now that's off patent in the United States, and omadacycline. So those are some other ones that you may hear about and you may want to consider in your strategies. I do remember there was a practice pattern, and Krishan, you can tell me if it's still something that's done in Canada. It wasn't done in the US. This is many years ago, where you would bring patients back and give them repeated doses of like intravenous antibiotics like ANSAF or something like that. And they'd have repeat visits until the clinician felt satisfied that they were turning the corner.
That still exists, and especially in communities that don't have OPAC clinics, that happens a lot.
Interesting. And then there were studies with probenecid to see if you could make that like a Q12 24-hour regimen. But what I want to get to, if you'll give me the next slide, is a study that we did, sort of testing the idea that and the utility of these very long-acting single-dose parenteral antibiotics, if their use could result in a significant decrease in hospital admission rate, and if they could be used safely as an alternative strategy and potentially a less costly and more convenient strategy to treat people with serious skin and soft tissue infections. So this was a pre-post study. It was done at a number of those institutions I showed you on the map before. We took people with substantial skin and soft tissue infections, like they had to be at least bigger than a cell phone area, but they were actually, I'll show you, more like an iPad. You'll stick with that analogy. We excluded people with indications for hospital admission, like I referred to, necrotizing fasciitis, sepsis, homeless, stuff like that, or where we didn't trust that they would follow up, because we needed to follow their outcomes. And this was a pre-post study. So we took these individuals who had severe skin and soft tissue infections, who potentially could go home. They didn't have any contraindications to sending them home. And we observed their hospitalization rate. And then in the next phase, we introduced Dalbavancin, and every patient who came in with these skin and soft tissue infection characteristics got a dose of Dalbavancin. And the providers, the clinicians, were educated about Dalbavancin, just like what George said. It's a single dose. It should be sufficient to cure their skin and soft tissue infection. Just with that single dose, no oral antibiotics were necessary. And then we observed what they did in terms of deciding whether or not the patient should be admitted. And our primary outcome was the hospitalization rate. And we tested the hypothesis that the hospitalization rate would be reduced, for example, from 45%, which we projected, down to 30%. And this is the study's flow diagram. And we followed people through 44 days. But the primary outcome was hospitalization rate at 14 days. And we had about 120, 125 patients in each arm, the before and the after arm. Next slide. And these are the characteristics of the groups. They were comparable in each phase of the study. These are average age was like about 50, and these tended to be larger people. So the median BMI was about 30 or 32, about 20% had diabetes. Most common skin infection was, just like we're talking about, cellulitis. And the median, sort of the middle size, was the size of an iPad. So that's what you guys probably think in centimeters, but that's what 255, 289 square centimeters would look like, at least like an iPad. And that's the average, so half were bigger. And about 20% met SIRS criteria, and about 25% had an elevated white count. Okay, next slide. And here's our main results. So remember, we were looking at hospitalization rate. We came pretty close. In the usual care group, 38.5% were hospitalized. With the introduction of Dalbavancin and education, this was reduced more than half to 17.8%. 0.6%. The length of stay was also less for those patients who were hospitalized and who got Dalbavancin. And through 44 days, the reduction in hospitalization held up, a very significant difference, and one that was potentially cost savings, which gets us to the next slide, which is sort of how might this work out? The wholesale cost at the time we did the study of Dalbavancin was $4,600, or about $1 million Canadian dollars. No, just kidding. 4,600 US dollars. And the cost of a hospital day is estimated at about $2,400, and the average length of stay in the usual care arm was 3 days. So that was over $7,000, which, you know, based on this back of the napkin calculation, would seem to be a cost-effective strategy overall. To the individual, I can tell you some of the patients I've offered this and treated, like some who had bad infections where I would feel better if they were in the hospital with their leg up and getting nursing care, being sure that they were getting and taking their therapy, insist that they had to, they couldn't leave work, and they needed to take care of personal things at home, and they elected for this strategy. So they were very happy. We can imagine, how these strategies affect patient productivity, let alone satisfaction. So, there's just this study gives you an idea of how this might relate to changes in practice.
Great, thanks very much, David. That's really, really helpful. So that takes us to the end of the didactic portion of this webinar, where we've been able to cover the burden of disease, optimizing management of skin and soft tissue infections, some clinical pearls about diagnosing necrotizing fasciitis, and a nice review of some of these newer antimicrobials that are now becoming made available in Canada. So I think this is a great segue into answering some questions with our expert panelists here. So I'll have you both turn on your cameras, and let's just have a nice conversation about some of these great questions that have come in. George, I'll start with you. There was a really good question that came in about diabetic patients and the consideration for covering for Pseudomonas. What are your thoughts on that?
I think David and I should both answer this question. Let me start. Our typical risk factors for pseudomonal infections include patients who are on oral steroids, patients who've been on antibiotics in the last 90 days, patients who are immunocompromised. In terms of respiratory tract infections, history of chronic lung disease or bronchiectasis, someone who's previously had a pseudomonal infection or is colonized with pseudomonal infection, those are the typical risk factors. Diabetes is very controversial in the literature, whether it's a true risk factor for Pseudomonas aeruginosa infections. I personally think it's very, very weak as a risk factor for Pseudomonas. I do not think a patient coming into the eMERGE with a cellulitis who has diabetes, automatically you need to be thinking Pseudomonas. I think you continue to think streptococci, such as Strep pyogenes, which is group A strep. I think you're thinking Staph aureus. It could be that as well. Could potentially be MRSA, but cellulitis is a streptococcal disease. Pseudomonas is way down on the list, and I don't want you to be beating everybody with ciprofloxacin or levofloxacin, chasing Pseudomonas, knowing that the quinolones, their coverage of streptococci is not nearly as good as cephalexin or cloxacillin or some of these other agents. David, give us your thoughts.
Yeah, first let's define things. Like there's diabetics with skin infections, sometimes skin infections of their foot, and then there's diabetic foot infections, which are really referred to like an infection of a chronic wound, right? In a patient with advanced diabetes and arterial insufficiency and neuropathy, and, who's probably going to wind up with an amputation sooner or later. For the diabetic who has a typical trauma or a skin abscess or something like that, they are infected with the same things. They were in our studies. They get treated the same way we talked about. So I agree with George there. Oh boy, diabetic foot ulcers, that's a whole nother deal. First start out with, like, just because there's an ulcer there maybe a little redness with some, attempted healing around it, that doesn't mean that it's infected. Like, stop yourself. But the ones that are infected become more clinically obvious. I think the important thing there is like, try to get a good deep culture. And then the results of the culture can be followed up. I would start with narrower spectrum agents for most people, and then see how they do, and then use the culture to help adjust that. This gets beyond emergency medicine. However, the other thing that goes into what we do depends on our chance of being wrong and the consequences to our patient. So when you see that diabetic foot ulcer patient and they're pretty sick and they have a big area of infection, and they're telling you that they're bound to, those can develop into necrotizing infections and lead to amputation. And so guess what? Our duty is to the patient's outcome, not to the stewardship shamers at that point. And there you're going to cover for anaerobes and Pseudomonas and resistant organisms. And you're certainly, like George alluded to, going to be guided perhaps by their past microbiology and their resistance profile. So I try, sorry, I made that more complicated than it probably needed to be, but that's how I look at it.
That's very helpful. Another important question that's come up a number of times is dosing of cephalexin. So traditional dosing is 500 milligrams QID, and the therapeutic range can be up to 1 gram QID. So many clinicians are starting to do that. So first, maybe George, if you can give us some of your insights in terms of the dosing of cephalexin.
You know what? I think this is a good question for all three of us to answer, because I know you've done some research with that, Krishan. David has experience. I'm going to give you some pharmacology numbers. Don't fall asleep on me. You give a patient in the emerge a gram of cefazolin. You're going to peak out in the blood about 200. I just want you to remember that. You're going to peak out in the blood at 200 micrograms per ml, has a 2-hour half-life, and it will start to decay over time. You give cephalexin 500 milligrams. ER docs love to talk about that as 90% bioavailability, and that's true, it's fantastic. But the serum level is 20 micrograms per ml. So remember, cefazolin, a gram IV is 200, cephalexin 500 milligrams is 20, and it's got a half-life that's half as long, it's 1 hour. Less peak, the drug is cleared faster. I think, I like to be guided by clinical evidence. There's very little clinical evidence out there in terms of RCTs, in terms of a higher dose cephalexin. But I like guiding clinicians, especially in the first day of therapy. Give 1 gram QID of cephalexin for that first day, then back off to your traditional dose. The vast majority of ER docs are going to use 500 4 times a day. I like the higher dose, especially in the first few doses. Just get the drug on board as quickly as possible, and let's kill those streptococci or those staphylococci as rapidly as possible, and then get clinical improvement, which will take days 2, 3, 4. David, what do you think? And then Krishan, tell us a little bit about your study.
No, I'm not, it makes sense what you say. The studies, we did, like cellulitis, we use standard dosing, which you probably saw, Krishan, seemed to work okay. But, whatever, we had 85% clinical response, maybe it'd be higher if we used a higher dose. We certainly have plenty of people. One thing that governs levels is the patient's weight, right? And I don't know if you have problems with obesity in Canada. But, you're close to Minnesota, so you probably do. And that's a joke about Minnesotans. Am I safe?
Safe.
Yeah. So, that's the bigger the person is, the lower levels you achieve. And then, that's one thing that goes into it. So I'd be interested in hearing about your clinical trial.
Yeah, so that was our theory. I totally agree with your point about obesity. In patients with a higher BMI, we were likely underdosing these patients at 500 milligram dosing. And so The theory is if we can reduce treatment failures with a higher dose, then we might be able to reduce unnecessary IV antibiotics and hospitalization. So we just finished a pilot randomized trial. We had 66 patients in total, 33 in each arm, randomized to either 500 milligrams plus placebo for 1 week or a gram QID for a week. The preliminary results show that there are fewer treatment failures. It was 1 in the high dose group and 4 in the standard dose group, although we can't use pilot data to really inform clinical decision making. So clinically, if I see a patient with a high BMI or a history of treatment failure, I'll start out at a gram QID. And I think we have time for one more important question, and I'll start with you, David, about treating patients with abscesses with antibiotics, which is a little bit controversial. What are your thoughts on that?
Well, I like to think we resolve the controversy, but so another part of that NIH grant was we did by far the largest careful study, a double-blind, randomized, placebo-controlled trial where patients with skin abscess coming into the ED, our setting, with ultrasound to both identify the abscess and ensure that the drainage was adequate. Were opened. We did pack them. We didn't use loop drainage, whatever, and followed very carefully. And then they got randomized to trimethoprim sulfa, kind of a higher dose, like 2 double strengths BID for 7 days, or placebo. And we showed that it was a statistically higher cure rate, a much higher, even higher, a greater difference if we looked at not only the need for a new antibiotic prescription, but a new drainage procedure as well. There were far fewer recurrences, and this was pretty amazing because this was just anybody presenting with an abscess, not somebody with recurrent infections in an ID clinic. There's just people off the street. The rate of a new skin infection in the next 6 to 8 weeks in the placebo group was about 20%. 20%, which went down to 10% in the group that got trimethoprim sulfa. Hospital admissions weren't frequent, but they were cut in half. And the really, really, really interesting thing that we just explored was we asked patients, like, was there anybody in your household who developed a similar skin infection? And infections in the household context were significantly reduced too. It's $5. So you get pretty good bang for your buck. And so I think, look, let's be honest. I think most doctors gave antibiotics when they drained an abscess. If you ask them, they say, oh, no, there's no evidence. But if you look at what they did, most of them gave antibiotics. But for the, 20 or 30%, especially academicians who wanted to say, well, I'm sorry, there's no good data. Now there's good data. It wasn't just my study, because the NIH sponsored another trial in parallel, which showed exactly the same thing. So I don't see it as a controversy. At best, you could say it's a shared decision-making thing. I mean, there are people who just don't want antibiotics, and the cure rate with IND alone is still pretty high. But if you want the best outcome for your patient and they want the best outcome, antibiotics is the way to go. And we didn't see a significant difference in adverse events. We had no Stevens-Johnson syndrome. Just if that happens, that's a bad day. I get it. And we also couldn't show any difference in development of invasive infections because they're probably too rare. But occasionally someone with an abscess comes back 3 months later with an epidural abscess or necrotizing. That's just how weird Staph aureus is. So, all right.
Very helpful, for sure. I think there's so many more questions I wish I could ask you both, but we are running out of time. So I think that just means that you're both going to have to come to the next CAPE annual conference to give us some more talks. I'd like to thank both of you, Dr. Zanel and Dr. Talon, for sharing your expertise and experience with us. You provided us all with pearls and tips for our next encounter with these patients. I'd also like to thank everyone who joined us tonight at this webinar, the Scientific Planning Committee for their invaluable input, and the CAPE staff team for their work behind the scenes, and our IT support. This session has been accredited by the College of Family Physicians in Canada and the Royal College. So please don't forget to complete your evaluation form and claim your credits. A certificate of attendance will be mailed out by Kate together with the evaluation link. Have a great night, everyone. Thank you again.
Thank you, everyone. Bye-bye.
See you in Toronto.